Hello, I'm Dr. Raymer, and today we're going to do a little neuroimaging primer. Now, the goal here is obviously not to become a neuroradiologist in the span of the next 20 minutes or so. You can see the learning outcomes here, and they're sort of geared toward using imaging modalities to inform our study of functional neuroanatomy. But a little knowledge about neuroimaging is just really useful life knowledge. When you or someone close to you has some brain imaging done, it's nice to have an idea about what you're looking at and what it might mean. And this just makes for much better conversations with the clinicians you'll interact with. So let's get going. So conceptually, neuroimaging modalities can be classified into two big categories: structural imaging and functional imaging. Structural, difficult to say, imaging, as the name implies, is specialized for studying brain structure. So useful for detecting structural damage and abnormalities, as well as for measuring structural parameters like changes in brain volume. And that could be volume of the whole brain, measured between cortex and skull, or volume of specific brain regions like the hippocampus or brain nuclei. Lots of neurodegenerative diseases and psychiatric conditions are associated with changes in volume in specific parts of the brain. So that's one way structural imaging is used. We have sort of two big modalities, CT and MRI. Those are the two big ones for structural imaging. There's also some less common ones. One of the most common, less common ones is DTI imaging. It's also called diffusion-based MRI, or diffusion tensor imaging is the full name. And so DTI imaging, not DTI imaging, that's redundant. DTI is structural. So we have CT, MRI, and DTI. These, of course, are MRIs. This is an MRI in the axial plane. This is an MRI in the coronal plane. And if you remember your orientation, anatomical orientation or radiological orientation, this is the left side of the patient in both cases. So the left side of the patient is on the right side of the image. In the other camp, we have functional imaging, and these are modalities specialized for studying brain activity. They're sort of used in two ways. The first is to assess what we'll call baseline activity in different parts of the brain. So if you tell someone to do nothing but just lay still, that's what you're measuring or trying to measure. The other is to identify brain areas and processes associated with particular tasks. So that's task-related activity. What happens in the brain when I recite the alphabet? What happens in the brain when I reach out and grasp a cup and bring it to my lips? So those are task-related functional studies. The two major, most common functional imaging modalities are functional MRI, so fMRI. So we often distinguish between the MRIs. fMRI is functional MRI. And this MRI, if you want to be really clear, you can put a structural in there. Structural MRI. Good. And this, what you're looking at, is PET, positron emission tomography. So that's what these images are. This is an axial, obviously, and a coronal PET image. Now, in addition to these two, fMRI and PT, there are other important functional imaging modalities, and I would be remiss if I didn't mention EEG, electroencephalography, and MEG, magnetoencephalography. And so we'll talk a little bit about those as well. So let's start with structural imaging, and the first one we're going to talk about is CT. CT is based on the principle of X-ray imaging. So from standard X-rays, X-rays are also used to produce images in CT. And the way X-rays produce images when they pass through the body and impinge on a detector on the other side of the body is due to variability in tissue density. So the X-rays are differentially attenuated by different body tissues according to density. A standard X-ray, like you might get if someone's investigating an ankle to see if it's broken or sprained, you get about 5 different density ranges, and dense structures appear bright. So If you have a metal implant or a contrast agent, that's brighter than bone. Bone is brighter than soft tissue. Soft tissue is brighter than fat, and fat is brighter on X-ray than air. And so brightness on X-ray imaging, like CT, equates with tissue density. And this is the picture I always use to reinforce that notion, which is funny X-rays in the emergency department. And you can see a few. Engagement ring hidden in the dessert, ends up in the stomach. A very common one, which is vibrator lost in the rectum. In this case, actually, salad tongs were attempting to retrieve the vibrator, and then the salad tongs were lost in the rectum, sort of the hole in the bottom of the sea phenomenon. And here's, of course, Buzz Lightyear going where no Buzz has ever gone before. Weirdly, feet first, which is an interesting choice. So these are just examples to reinforce the point that dense structures are bright. So CT also uses X-rays, so the density principle still holds, but CT essentially captures many, many measurements of density across a single slice of the patient. So rather than a single view through a patient, CT isolates a slice with a source of X-rays placed in opposition on a ring of an array of detectors. And that spinning around the body is what isolates a slice of the patient. The upshot of this is with CT, compared to standard X-ray, you get a whole bunch of soft tissue resolution that are missing on a standard plain film X-ray. And you can see this with the image of the abdomen, so you can see all the organs nicely shown. Here's the left kidney, for example, on CT. When it comes to the brain, axial CT images are often a little bit oblique to limit radiation exposure to the eyes. And you can see that here. So here's the orbitomeatal line. That shows you where the true horizontal plane of the image is. And you can see that all of these lines, which are CT slices, are oblique. And that tips up to miss the eyeballs. So this isn't an issue with MRI. So when you look at an MRI that's axial, it's generally truly axial. When you look at a CT, it's often oblique for this reason. This is what's called a scout image. So this is showing the position of all the subsequent images, the axial level of all the images that you would have in a file of images on a patient. So we describe the relative appearance of structures on CT using density, and we use these terms hyperdense and hypodense. And here's the range of sort of density structures for the brain. Again, dense structures appear bright, and congealed blood, when it's newly congealed, is bright on CT. So that's an important diagnostic tool or feature. You sometimes hear density expressed in Hounsfield units. This is a really weird scale. So the Hounsfield units, water has a density of 0, and air has a density of negative 1,000. So just in case you hear that term. The range that you get in terms of density on standard unmodified CT is diagnostically useful for some types of damage, obviously like acute bleeding in the brain, but not others. And one of the others it's not great for is acute stroke. So the utility of CT can be enhanced for other applications like detecting stroke using intravascular contrast agents. So here on the left, we're looking at a normal unmodified CT, a CT without a contrast agent infused. You can see that the cerebrospinal fluid is hypodense to the surrounding brain tissue. The skull, of course, the bony skull, is hyperdense to the brain. On the right of this image, you see CT with intravascular contrast agent used. So it's a radio-opaque or radio-dense agent, typically containing iodine is the most common. And here, then you can see it's highlighted the arteries. So here we see the middle cerebral artery and the anterior cerebral artery and the anterior communicating. In fact, I can trace around the circle of Willis, except for my posterior communicating is out of the plane of this section. And so you can see the arteries. It's one way to enhance CT and the utility of CT with intravascular radioopaque contrast. So when do you use CT? Well, obviously it's much better for imaging soft tissue than conventional radiographs, right? So we get soft tissue resolution out of it. It is cheaper and faster than MRI. And it has another advantage for trauma when you can't interview a patient, which is it's safe for people with metal implants, and with potentially with things metal in their eyes or other parts of their body, if they're an iron worker or something like that. Of course, it provides much less anatomical resolution than MRI. So that's the trade-off. There's also a couple of other things just because of the properties of CT versus MRI. For example, CT is better for detecting fresh bleeding in the brain. MRI better for detecting old or chronic bleeding in the brain. So that informs the decision making when to use a CT, when to use an MRI. So MRI, and in this case we're talking about structural MRI, definitely provides better anatomical resolution. The important point to remember, of course, is that it's not based on density. So this is not using X-rays. Instead, tissue contrast in MRI is produced based on different levels of protons, proton content, and how the protons behave in different tissues. So we don't say hyperdense and hypodense. When we describe MRI images, we talk about hyperintense and hypointense. So how are those images produced? In a very rudimentary way, they're produced, the signal results from protons relaxing back into alignment with a net magnetic field. So when you go into an MRI scanner, this big scanner, that is creating a net magnetic field across your body. So that's the external magnetic field. That's what the field applied by the scanner. The perturbation of that field is created by a coil. So the coil is isolated, in this case, over the patient's head. That's the coil that perturbs protons within that magnetic field. It knocks them out of alignment. And when they're knocked out of alignment, gradually they relax back into alignment. And that's the signal you're measuring on an MRI, is that relaxation time. So there's two components to relaxation. They moving along different axes, and different imaging protocols in MRI are used to distinguish tissues based on their differences in each component. So a T1 weighted image discriminates between tissue based on their T1 relaxation time, and a T2 weighted image discriminates between different components in different tissues based on a T2 relaxation time. And that's all these mean. They're just measuring different parameters of proton behavior in the scanner. So T1 weighted images and T2 weighted images, in a very sort of simplistic way, T1 weighted images, we remember that they tend to look like normal anatomy. So in a T1 weighted image, things look the way we expect them to look. Gray matter is dark relative to white matter, and the fluid in the ventricular system, CSF, is dark. In contrast, T2 images in a simplistic way are often described as the photonegative, a negative of a T1 weighted image. And in T2 weighted images, one of the most obvious things that you see right away, you know you're looking at a T2, is that the fluid in the ventricles, the CSF, is very bright. So T2 fluid is bright, T1 fluid is dark. Another sort of simplistic categorization is that we often use T1 weighted images to look at normal anatomy and T2 weighted images to detect pathology. And that's a little bit of an oversimplification, but somewhat true. T2 weighted images, the fluid in the ventricles is so bright that it tends to obscure edema or other pathology adjacent to the ventricles. So the way that people get around that is they use FLAIR, fluid attenuation imaging, something like that. And FLAIR produces images that are similar to T2, but the CSF appears dark. So this can improve detection of pathology like edema adjacent to the ventricles. Otherwise, adjacent to a bright ventricle, a bright patch might be easy to miss on T2. And so these are just 3 types of still structural MRI, T1 weighted, T2 weighted, and FLAIR, that you're likely to encounter. Now, diffusion tensor imaging is also based on proton behavior. So it uses magnetic resonance imaging, but in a different way. So what it measures is the restriction of water diffusion at each voxel, which is obviously a 3-dimensional volume in a brain, to map axons. And the actual measurement that it's collecting is fractional anisotropy. In this case, that's the tendency for water molecules to diffuse along the long axis of an axon. So if you had isotropy, you could think of a space as a sphere. So there's no probability of protons, water molecules, diffusing in any direction. They could go anywhere. They're not restricted at all. They're not going to bounce off the walls of that sphere. In low anisotropy, they're similarly unrestricted, but they're going to bounce off the walls sooner. And as anisotropy increases, the direction of travel of those water molecules and their protons is restricted. And so the high fractional anisotropy is interpreted as increased white matter integrity in white matter regions of the brain. And what these FA measurements look like when they're mapped out is images like this. And so they're displayed using fiber tractography. And this is essentially color coding, with the colors representing which direction the axons are traveling. So here we're looking at a coronal section of the brain. Red are transverse fibers, so the corpus callosum fibers would be red on this map of axons traveling left to right in the brain. Green actually maps anterior-posterior traveling fibers, so those would be association tracks, all the tracks linking different parts of the brain in the same hemisphere. And the blue is craniocaudal fibers, and you can see those, probably the bulk of them descending from cortex down through the internal capsule and traveling into the brainstem and the spinal cord. And so these are just color-coded maps of the predominant direction of axonal travel in each region, and with analysis, the integrity of axons in a brain region. Okay, so let's switch gears and talk about functional imaging. And these, of course, are modalities specialized for studying brain activity. So we've got fMRI and PET, and although I forgot to put them on the slide, of course, we've got EEG and MEG, electroencephalography and magnetoencephalography, that fall into this category. So let's start with fMRI. So fMRI measures changes in brain metabolism based on regional oxygen consumption. So bits of brain that are metabolically active consuming more oxygen. And the principle underlying fMRI is the BOLD effect, blood oxygenation level dependent effect, which essentially means that the effect is that when a bit of brain uses more oxygen, the MRI signal changes. And it changes due to the relative ratio of oxygenated versus deoxygenated hemoglobin in the region. Now, you can use fMRI, of course, in myriad ways in research and clinically. One way is going to be our example here. You can localize regions of the brain that are involved in a task. And you might do this, for example, for pre-surgical mapping of eloquent brain regions like Broca's area, which is used for expressive language. So if you have to resect a brain tumor, you want to avoid Broca's area. Now, if we know where Broca's area is, why can't we just avoid it? Well, the important answer is that Broca's area, and in fact every brain region, is a little bit different in every individual. That's why we do pre-surgical mapping like this. So the most classical use of MRI is a boxcar design or a block design paradigm. And so you have task periods that are interspersed with periods of quote unquote brain rest. And I'll explain why I'm putting that in quotes in a minute. And so it's an on-off design. Here, the patient was asked we're planning a brain surgery. We want to avoid Broca's area. So they put a letter on the screen and said, okay, think of as many words as you can that start with that letter. It's an I can't even say that, orthographic lexical retrieval paradigm or test. And during the rest period, don't do that. Just do nothing. And so when you do a block design fMRI, you get an activity map that results a subtraction. So it's a subtraction of brain activity or brain metabolism in each region during the task minus activity at rest. So in this example, the resulting activity map highlights language areas like Broca's and Wernicke's, and you can see some portions of the frontal lobe are also involved, and that makes sense. People are thinking, not just speaking, right? Okay, what begins with O? And so that makes sense for that type of map. Now, this is the reason I put rest in quotes, because of course the brain is never doing nothing. The primary alternative to task-based MRI is resting MRI. And in fact, it was functional MRI in a boxcar design like that led to the serendipitous discovery of the default mode network. So people finally noticed that, wait a second, when we tell people to do nothing, there's still something happening. There's consistent activity in interconnected regions of the brain. So these are brain areas that are actually deactivated in a task and show correlated activity at rest, right? At rest in quotes, because the brain is never doing nothing. So the default mode network, which most people now agree consists mostly of these regions of the brain and their dense network connectivity, is implicated in all kinds of diseases. It's under intense investigation, and the default mode network is involved in things like daydreaming and mind wandering. And so you've experienced the default mode network being told when the last time you tried to do nothing, and the default mode network is activated. Now, positron emission tomography, or PET scanning, uses radioactive tracers. So it's a little more invasive because you have to inject a radioactive tracer into someone, but it's also more specific. You can measure regional changes in a whole bunch of physiological processes. So you can measure metabolism, like fMRI, albeit via a different mechanism. You can also measure enzyme activity and protein accumulation and receptor binding. So it's a more flexible technique, slightly more invasive technique. The way this works is a radioactive tracer or radio tracer that's something labeled with a radioactive isotope. And the isotope degrades and emits a positron, which ultimately collides with an electron, and that produces the measurable signal from PET. So it's degradation of a radioactive isotope in the brain that's creating the signal. The isotope can be attached to a whole variety of ligands. The most common is fluorodeoxyglucose, which is actually radioactive glucose. So if you see the abbreviation FDG, that's FDG PET is a measure of metabolism, similar to fMRI, different mechanism. PET can also be used, for example, to monitor neurotransmitter activity and neurotransmitter production. And so in order to look at a PET image and interpret any kind of result, you have to know what the ligand is targeting, right? So this is a map of radioactivity where hot colors typically represent high activity and cool colors typically represent low radioactivity or radioactive accumulation. You have to know what the ligand's targeting to interpret it whatsoever. And so F-DOPA, for example, is radioactive DOPA. So F-DOPA PET, F18, is a measurement of local dopamine or norepinephrine synthesis, because DOPA is the precursor for production of those neurotransmitters. Now, EEG, or electroencephalography, measures direct electrical activity of neurons. So it's more direct than either fMRI or PET, because it's measuring the electrical signals, albeit from synchronized activity in dendrites. so not individual neurons. The electrodes are located here, so outside the scalp, right? So they're sitting on the skin, and you may have seen these skull caps that are covered in little electrodes with wires running to them. That's an EEG skull cap. And in this case, EEG is being used to pick up resting or spontaneous activity. And this reflects a functional state of the brain. So you can see here we've got sort of characteristic features of EEG, brain activity in different states. And there's a beta rhythm associated with excitement. Alpha waves are a feature of EEG associated with relaxation, and so on. And you can somewhat reliably determine state of consciousness, including things like coma, via EEG. EEG can also be task-based, and this is called event-related potentials, or ERPs. And so during a stimulation or a task, the EEG is time-locked to the stimulus. This produces characteristic peaks on EEG. This is a little more detail than I want to get into, but the peaks on an EEG that's related to a task have different functional links. So the first peak, for example, the N1 peak, is linked to the detection of the stimulus. In this case, it's an auditory stimulus. And so we have the first peak being related to stimulus detection, and the P3 peak, another characteristic peak, related to the frontal cortex response. So inhibiting awareness, integrating, etc. And the interesting thing is not only resting brain activity can change, as we saw in the previous slide, with different consciousness states or other states, for example. Event-related potential activity can change between populations of people and individuals. For example, the P3 peak is reduced in schizophrenics and psychopaths, and that's thought to be related to a loss of inhibitory control. And finally, we have magnetoencephalography, or MEG. So EEG measures electrical activity or aggregate electrical activity in neurons. MEG measures the magnetic field that the electric current traveling in neurons produces. So the little electric current, the little tiny magnetic field that the intracellular current produces. You can tell my colleague who uses MEG wrote this slide because he remarks that it's the best combination of spatial resolution and temporal accuracy. We'll debate that, and we'll show you in a moment what that means. But this is what MEG looks like, and so you have to you're somewhat restricted because you need your head immobilized in this relatively huge device to perform MEG. And it's a relatively new technique. So EEG is quite old, MEG is relatively new. But people argue, of course, that the spatial resolution of MEG is better. One reason it's better is that the magnetic fields are less distorted as they travel through depth in the brain. And so you can get deeper structures imaged with MEG, or detect activity in deeper structures than you can with EEG, because the magnetic field distorts less than the electrical signal. So all of these functional imaging modalities have different advantages and limitations to them. And we often talk about them as being different in terms of their temporal resolution and their spatial resolution. So temporal resolution, let's take MRI as our fMRI as our starting point, because that's the one I'm most familiar with. So fMRI, it's MRI, so it has the best spatial resolution of any of these modalities in terms of how small a structure you can localize a signal to. fMRI is the best. It's not the best, though, in terms of temporal resolution, because you're measuring oxygen consumption, and you're measuring it indirectly. So you're not measuring direct neural activity. So its temporal resolution is a bit crap. EEG, on the other hand, is the opposite. So EEG has terrible spatial resolution. It's very difficult to see where you are in the brain precisely, But the temporal resolution is perfect because, not perfect, but near perfect. Nothing's perfect. But you're measuring neural activity directly, right? It's not an indirect measurement that you're taking as a proxy for neural activity, the way it is with fMRI. PET is even slower than fMRI, but it's very specific. So you can use, you can tailor a PET study to measure all kinds of different things, not just metabolism like fMRI. And MEG, as we've already alluded to, is an intermediate. So it's still fast. It's got great temporal resolution, because it's, again, a direct measurement of neural activity, this time via the magnetic field generated by neurons that are signaling. It's got better spatial resolution than EEG. So that's why it's an intermediate there. So these are just some of the considerations that we think about when we decide which imaging modality to use to study specific aspects of brain activity.